Well, thank you very much. My name is Charlton Wilson. As mentioned, I'm the Chief Medical Officer for Mercy Care Plan. And today my objectives to share with you are to describe the role of health literacy and cultural competency within the delivery of health care, and particularly within the needy populations who have both significant physical as well as behavioral health conditions. Secondly, I'm going to talk to you a little bit about the kinds of activities that are occurring within the Medicaid system in the state of Arizona and the approaches based on class and other forms of standards that we are using and applying to try to improve the effectiveness of our services and the ability to reduce inequities. I'm going to do so in talking today using my experience within the state Medicaid system, and hopefully out of that actually provide some data that will be new and interesting to you. And this is the first time, in fact, that some of the data I've had an opportunity to share, so really interested in getting your insights and feedback from it. And if I'm successful at the end of this session, what you'll actually do, and what my own personal goal for this presentation is that the next time that you're thinking about how do I help our community, you think about a health plan, and a Medicaid health plan in particular, as a potential partner. There we go, advanced the right way. Well, first, a little bit about Medicaid. As you know, Medicaid is the program that is federally funded but operated by the states. It is actually, and funded as well by the state. And some important things to know is that in the state of Arizona, the Medicaid program is called ACCESS, Arizona Healthcare Cost Containment System. It's actually, I'm going to describe in a little bit about how it operates healthcare programs, and that's particularly important because as you think about different populations and relationships that you may have, understanding and a better understanding about how the Medicaid systems should help us be more effective in our reaching of special populations. And I include that to mean special populations that have significant behavioral health concerns. Medicaid is largely driven by financial eligibility. So in general, there are some other requirements for participation in Medicaid, but in general, it is a program for lower economic, socioeconomic status people. And that's going to be important, and I'll make some links to racial and ethnic groups within that. And then finally, the other reason that my main goal of thinking about this is Medicaid is big. It covers over 1.6 million lives in the state of Arizona, and that number is increasing and probably will reach 1.8 or more over this next year due to not only the large number of people who are eligible, but the challenges that many people are experiencing in our economy. So what's the connection between Medicaid and racial and ethnic groups? Well, this is a slide that you can go to the web and get yourself. And if you don't use Arizona Health Matters for capturing information about communities, I really encourage you to think about that as a resource for you. It's a website that actually pulls together any number of information, including information in and around disparities. This is actually a chart, and overall in the state of Arizona in this time frame period, overall about 17.9%. I think that's fairly similar to some numbers that you heard earlier presenters give today. 17.9% live below the poverty level. And yet, when you take a look at this, you can see that certain groups, American Indian, Alaskan Native, Black, African American, Hispanic and Latino, and Hawaiian and other Pacific Islander, as well as other minority groups, actually are overrepresented in the poverty population. That translates into eligibility and participation in the Medicaid program. So this is a graph that is a combined set of data, both from Arizona Health Matters on general population, as well as from data from ACCESS and ACCESS enrollment, so enrollment within the Medicaid system. And what it shows is, and the green or the upper bar is Arizona ethnic and racial disparities, or ethnic and racial group prevalence within, or population within the entire state. And the lower, or the orange bar, is the access population. And what you see is that in access, or in the Medicaid program, is overrepresented Hispanic, African American, and Native American populations. Very similar to the distribution of these racial and ethnic groups by the income status. So there's an obvious connection between Medicaid and special populations. Let me take a little bit more chance then, or this opportunity then, to tell you a little bit more about the Medicaid system. Every state operates its Medicaid program differently. This program is actually operated within what they call a waiver program, which allows the state to create special groups, opportunities, special plans, and approaches that the state and its constituents think will most improve the health of the state. Some things have been around for quite a while. For example, public-private partnerships, where the state bids out managed care contracts to either public or private, profit or not-for-profit health plans that allow Medicaid eligible individuals to have membership in a health plan. Other things that are important that you know about: expansion of populations, even before the ACA came along. Participation in things for special groups, like those who are at risk of being in skilled nursing facilities for the rest of their lives, engagement in a participation in a program, the All-Tex program, that allows for things like home modifications and home sitter that allow a person to live more independently in the community. And then finally, things such as administrative processes that improve the system and make the system more sustainable. Well, only in the United States would this chart be considered a simplification, because we have a very complicated healthcare system, but this is more simple. And what I'd like to do is sort of use it to sort of describe why there's a connection between the access system, how it's organized, and the ability to reach certain populations. As I mentioned across the top, the access system as a whole, one, it's important to recognize that there is something called the American Indian Health Plan, or a health program. People who are American Indian, Alaska Native have the option of enrolling in either a managed care organization or in this health plan, and that is a particular important role in sustainability of our urban, tribal, and Indian health service programs. Acute care services are where most people participate in, about 8 to 9 different contractors right now across the state, and these are classic what people think of as health plans. And you see Mercy Care Plan there, the plan that I know well, has about 330,000 people who participate in this plan. The long-term care system, we mentioned that as well. I sort of described it a little bit. It's important for not only the special populations that are there, but also the fact that as people with developmental disabilities also participate in an All-Tex plan in a collaboration with the Department of Economic Security that allows for opportunities for people with developmental disabilities to live in a more independent setting than they might otherwise have. And then more recently, and I say this because this slide here is actually already out of date, 28 days ago, 29 days ago, the creation of integrated behavioral health authorities that surround services, particularly around those people with serious mental illness, as well as continuing some of the programs for general mental health and children's systems of care for those areas that they serve. And Mercy Maricopa is one of those plans that's now about 18 months old and is a sister plan to Mercy Care Plan. So if we have special programs that outreach to special needs and populations, what does this look like? And I'm going to just share some information about what I know best, Mercy Care Plan, and tell you a little bit about how do racial and ethnic diversity and health literacy and cultural competency play a role into our programs. First, what I'm showing you here is that within our populations, you can tell how they are quite diverse and actually very similar to what the distribution is in Medicaid as a whole. A little bit underrepresented in Native American populations because of the choice to use the American Indian Health programs. Within that information as well is information that comes across about language choice and language preference. What you're seeing here is a slice of our acute line of business within Mercy Care Plan. And yes, about 4 out of 5 people do have English as their primary language, but about 1 out of 5 have a language other than English as their primary. Certainly Hispanic and Spanish languages are the predominant of that group, but increasingly in what a wide variety of different languages and cultures are represented here. Recently, we have met the threshold of 3,000 members to begin translating all of our materials into Arabic as well. And I was sharing that with some of our partners recently, talking about how large and sharing that the impact of the refugee population on the Medicaid programs. Well, the next sort of logical leap that I'm hoping you're following as I go along there, if we reach out to populations, if we have connections with them, and we have information about them, might that provide us the opportunity to actually think about, are we using the information in the very best possible way that allows us to reach out to and improve health for these populations? With the assistance of our Aetna Medicaid Administrator program, which is nationally housed here in Phoenix as well, we're now actually able to start parsing our data and using information to look at racial and ethnic disparities within the populations that we serve. This top graph here shows that within Mercy Care Plan, and this is crude, unadjusted prevalence, so for those of you who are statisticians and population-like people, these are pretty rough numbers, but if you take a look at them and you look at the different rates that you can see a 30 or 40% different rate in the prevalence of conditions among different racial and ethnic groups of people in my health plan, people that I'm responsible for and feel a need to make sure that work well. Now, if you also use data from the Health Matters, you can see that remarkably, the rates of hospitalization by these same populations almost match 1 for 1. In other words, there's some connection. What we're seeing within our population is contributing to disparities within the population as well. So if we can come up with processes and programs that address those differences, and if these are quality differences, those quality differences seem to be very much also racial and health equity issues as well. And while we often think about how we improve programs that way, maybe we need to be thinking about, are we addressing and participating with the communities that we serve? But it's even more than that, and I share this information here, again, looking at data from Mercy Care Plan as well, and crude prevalence rates. But there's differences in some of these relationships that we need to understand better. Now, I don't know, and I'm not an expert in the field of behavioral health and differences between different populations, but I can say that there are definitely differences here. Which of these are strengths and positive relationships between culture? Which of them are differences in our ascertainment and knowledge about what the populations that we serve? Changes in the way that our programs work, or accesses or barriers to care? We need to understand as much what the positives and differences are every time that we do these. So what are the things that we're doing? As mentioned earlier today, the class standards, and many of you in this room are very, very aware of them. We have many programs and all that actually are driven by and follow them very well. And we have that opportunity both for materials and then also for addressing our own employee population through training, competency development, and relationships. And also for the providers that we work with, so that there are trainings, accessibility, language lines, etc. But the other thing that is really important and what we are increasingly developing is, how do we use this information and grow, and how do we create partnerships with people who can actually help us achieve what are really community-based issues. So for example, everywhere from the Health Improvement Partnership of Maricopa County, which is a way of connecting with people who we previously haven't worked with, all the way through the work of contracting with people such as the Refugee Women's Clinic, transportation providers, et cetera. How do we build an intelligent network that actually improves the care that we do and engages the community in the development of the programs that we have? What are the further opportunities that I think exist? Well, one of them is certainly to take this information and drive it in programs that we know work. Plan, Do, Study, Act to improve healthcare. Next, to make sure that we continue to develop those relationships with non-traditional partners. And then finally, to make sure that as we look at Medicaid policies, that we help them to develop systems that will actually reach the communities that we need in an effective way. And with that, I believe I'm out of time, so thank you very much.